Hello, everybody, and thank you for joining us for yet another one of our MAG Educational Specialist Seminars. Today, we have got the very lovely Dr. Pankaj Rao, who is an orthopaedic surgeon specialising in all aspects of foot and ankle surgery. So those tiny weeny little bones in our feet that have to support our entire body weight and which we cram into ridiculous shoes and do all sorts of things with them. So the foot is a real niche specialty and it's such a critical part of orthopaedic surgery. Dr. Rao has trained in Newcastle there, but he's also completed his fellowship in Brisbane, and he has done studies in Thailand, the USA and Australia, and residencies and all sorts of things. And he's highly regarded for his expertise, and we at MAG are particularly proud to have him on our panel. Now, I'm going to ask if you could all mute yourself if you have not already done so, and I will mute anyone who is unmuted. The reason for this is so that noise from your home or workplace doesn't interfere with the quality of the recording or with Dr. speaking to us. This seminar today will go approximately 35 minutes, and at the end there will be time for you to ask your questions. But if you have to leave or duck out, please pop your question in the chat and I will ask it for you. So thank you so much for your time today, Doctor. Over to you.
Hello. Yeah, thanks all for joining. I've just organised to share the screen, and then we can get started. Okay, just need a thumbs up from everyone who can see those slides, please.
Yep.
Excellent. Okay. So the topic I was asked to talk about is, when is foot and ankle surgery absolutely necessary? I have rejigged it a bit just to say, when is it necessary? My name's Pankaj Rao. I'm an orthopaedic foot and ankle surgeon working here in Newcastle.
Yeah.
Just a quick bio. I'm 52. I work in Newcastle. I've done all my training in Australia via the College of Surgeons and the Australian Orthopaedic Association. I've been doing this for about 15 years now. All aspects of foot and ankle surgery. My special interests are in ankle sprains, syndesmosis, Achilles, and forefoot surgery involving bunions, claw toes, and arthritis. If you've got 5 seconds, please feel free to go to my website, www.rao.net.au. At any time that suits you. My medico-legal work, I haven't done a lot, I'll have to admit, and it's pretty much 90% workers' compensation patients, often ones that have been operated on and they're getting towards the end of their claim, and when they need to engage lawyers in order to try and get either a payout or get some sort of solution or resolution with the insurance company. The other time, of course, I've engaged lawyers is when I've been sued. The average orthopaedic surgeon probably gets sued once per year, and any orthopaedic surgeon who tells you they're not sued at least once per year is probably lying. My view on medico-legal work is generally this, and it's based on my experience. Whenever I do have to engage with lawyers in medico-legal work, I say, and I have been told this and I agree with it, that I am not a medico-legal expert, the lawyers are. So naturally, I might feel aggrieved that I'm being sued or something along those lines, but I need to be guided by the lawyers that I work with. Recently, I have done one of those free assessments for MAG. I really enjoyed it. There was a recent email regarding that sent out by MAG as well, which I don't know if everyone's read it, but I'm quite happy to do those. I found it quite enjoyable and a little bit of a distraction from my normal day-to-day grind as well. I'm more than happy to do those for people, case reviews, file reviews, seeing patients. Obviously, being in Newcastle makes it a bit different if everyone's in Sydney, but I'm happy to do them at relatively short notice. So the standard way that we divide orthopaedic work up is as trauma versus elective. So trauma is obviously if you have a major car accident or you break a bone. Elective cases when you have an issue and you decide, well, maybe do I need surgery for this? In the elective category, I would say there are purely elective cases and semi-elective cases. Michelle talked then about the small bones of the foot and fitting into tight shoes. What I'd encourage you to or keep on doing that because that gives me more work. No, just jokes aside. That's something like bunions, I would say, is almost a purely elective procedure, whereas something like developing some arthritis or wear and tear that causes pain is what I would call semi-elective. From a trauma perspective, we're looking more at things like fractures, dislocations, and long-term issues from trauma. I don't want to spend too much time on that with respect to discussing the need for surgery, because I think that's relatively straightforward and not controversial. And I want to try and nut out a little bit of the more controversial issues regarding foot and ankle surgery. So basically, in elective and semi-elective cases, this is my motherhood statement about foot and ankle issues. Most people with a foot or ankle problem either get better with minimal intervention if given enough time without surgery. And that would probably go for about 80% of the patients I see. I can have a day at work where I see 25 patients, 25 new patients, and none of them need an operation, really. And I can have a day where I get 15 of them need an operation. But most people in general will get better without surgery. The big question is, who needs surgery and when do they need it? The classic line that we would read in a medical textbook is something along the lines of, you have surgery when you have exhausted all conservative measures. And that's a real textbook definition. It's also a term that I really don't like to use a lot because it doesn't really explain what does it actually mean. Over what time frame do you wait? 6 months, 12 months, 18 months, 10 years? So exhausted all conservative measures is the typical line that you will read about people being ready for surgery, but it needs to be nutted out a little bit better than that in order to help decide regarding whether or not a patient needs surgery. Specifically for foot and ankle conditions, there's so many factors involved. It would have to be one of the most individualised aspects of orthopaedic surgery to deal with. There's so many factors involved with the injury itself, what the illness actually is, and a lot of the time it's about patient factors as well that naturally is can be quite idiosyncratic. So what I've come up with is what I call the foot and ankle ladder, and each run, I say, is around about 8 weeks. Now this, of course, can vary, but if you think about yourself, if anyone here has had a foot or ankle injury themselves, the first rung, I say, is what I call hope. You hope that you get better soon without having to do too much differently to what you've been doing. And I think hope in general lasts for about 8 weeks. Maybe 6 weeks, but around about 8 weeks. You then go to the next rung. You go after 8 weeks, oh, hang on, I'm not that much better. My foot's still sore. My ankle's still feeling a bit unstable. My ankle's a bit sore. The next rung to go to is seeking out allied health. And that's where you usually see a physiotherapist or a podiatrist. And again, I would say you need to allow yourself about 8 weeks of therapy with a physio or podiatrist. Often during this phase or this rung of the ladder, it involves obtaining some imaging, x-rays, ultrasound, CT scans, MRI scans, and starting some sort of therapy. This is I think, one of the most critical points for foot and ankle surgery and for foot and ankle surgeons. Probably around about 50 to 60% of my referrals, whilst people have to get a GP referral, are actually the result of a patient seeing a physiotherapist or a podiatrist, and that physiotherapist or podiatrist contacting me directly. So these are often very critical sort of people. And I've been luckily enough in Newcastle anyway to build up some good relationships with therapists that they know if their treatment hasn't worked after 8 or 10 weeks, it doesn't represent failure. It just means you've got to go to the next rung. And the third rung is seeing the GP. The GP may order some more tests, such as blood tests, different types of scans, and prescribe some medications, and probably suggests a specialist referral if the patient's not improving. And the final rung is me, the orthopaedic surgeon, and I make the decision on further management, Do we need to modify anything? And maybe do we need surgery? So if you think of this, 1, 2, 3, that's now kind of 6 months before someone really gets to me. So that whole process takes about 6 months before we know whether a patient needs to have surgery. Now, why does it take this long? And, you know, again, I'm trying to speak in general terms. There would be individual cases which are different, but nearly 80% of people with a foot or ankle issue will get better just following that pathway. And so by the time they come to me, it's often what I call a numbers game. And often I have to say to people 6 months down the track, they've been a little bit unlucky, because at the day that they either hurt themselves or developed their problem, there was probably another 9 other people who had the same issue. And out of that group of 10, around about 7 or 8 are completely better. So this is one of the issues with foot and ankle surgery, specifically in a workers' compensation case, where often you need to wait 6 months before you even decide if a patient needs surgery. Surgery for the foot and ankle should really only be considered after these measures have been undertaken. And I think whether it's over a 6-month period or a 4-month period, it really does need to be quite clearly categorised that a patient has at least tried these options. Otherwise, the decision-making regarding surgery, I believe, can be flawed unless they have actually done all of those things. What does annoy patients is that they lack the certainty about their condition and the natural process and what to do if they're not getting better. So a common scenario will be, I injured myself or I've developed this problem. I went to the GP. GP said I should get better in 2 months. 2 months later, I'm not better. GP says, well, let's go to a physio. Physio says, I'll get you better in 2 months. But then no one really has a plan for what should actually happen if they don't get better and what their actual goal and target and level of function should be. I think it's actually magnified in foot and ankle conditions, again, because most people do get better without surgery. I believe it is less so in other orthopaedic regions, such as the knee. So for example, if you have someone who's 65 to 70 years old with significant knee arthritis, it's a bit of a one-trick pony. That patient, if they see a knee surgeon, is going to be told, you need a knee replacement. There really is no other operation. And then it's a decision for them as to when or if they decide to go ahead with that knee replacement. But certainly this time frame of around about 5 to 6 months can be quite annoying for the patient if they lack the certainty about where they're actually going. So how do I decide if a patient needs to have surgery? This isn't something from a textbook. This is actually something that I've come up with probably after being in practice about 12 or 13 years. But this is something that I actually try and apply to nearly every patient that I see. And one of the things is this: most people who come to see me aren't turning up here with a 9 out of 10 pain. They kind of come to me with around about a 5 or 6 out of 10 pain that has just been persisting, and it's not getting better, or it gets a bit better but then gets a bit worse. But it's been persisting for quite a long time and they're now starting to get sick of it. So if I was going to suggest one thing that's worth either copying, or everyone gets a copy of this anyway, I understand, but this is probably the slide that I say to people is what helps to determine whether or not you need an operation or down the track. So pain or discomfort more days of the week than not. So luckily there's only 7 days of the week, so it's got to be 4-3 at least, one way or the other. Having difficulty doing the activities of daily living. So just being able to get up and do the things around the house that you need to do. Having difficulty doing the activities that they want to do. Now, this isn't age specific. So this could be the 20-year-old that wants to run 10 kilometres a day. It could be the 40-year-old that wants to try and do ultra marathons. It could be the 70-year-old person that just wants to be able to go to the shops and just to go play lawn bowls or golf. Having difficulty with off-the-shelf shoe wear. So again, I don't know how many people who are on today have had issues with their feet, but certainly if I have a number of patients who struggle because for one foot that might be a size 6 or 7, but for the other foot they might be like a 7.5 or an 8. That's what I call having difficulty with off-the-shelf shoe wear. If you're getting sick of their condition, if people are just getting, basically I just say to them, are you getting the shits with your ankle or your foot? And if they say, yes, I am, then they fall in that category. They've tried all the other options. They've had imaging and investigations that support the diagnosis of what we're trying to correct. And the final thing, if there is any doubt, seeking a second opinion. Now, I'm assuming in the medico-legal world, we often get a lot of opinions from different surgeons. Sometimes it's to support your legal case, I guess. Sometimes it's to support the defendant or plaintiff's case. In private practice, it's probably not done enough just to get a second opinion. And that's because orthopaedic surgeons are scaredy cats, and they think that if they send someone for another opinion, they're going to leave them and go with the other orthopaedic surgeon. To be honest, I was probably in that category when I first started in practice. I think that's pretty natural. But I think now I actually say to patients, if the other surgeon has a better idea than me about what to do, then please feel free to go with that option. Luckily in Newcastle, there's about 5 or 6 of us who are foot and ankle surgeons here. We all get on very well, very collegiately, and we actually all do things a little bit differently. So getting a second opinion can be very worthwhile. But these are the sort of 7 or 8 criteria that I use to decide if someone needs to have an operation. So I apply these on a daily basis. The issue for me is that the patient is often sent to me without having done any of those other measures, such as having medication or having been to a therapist or a physio or having given it enough time. I still struggle with this, but the most common issue I have is that a patient has not actually tried any medication to help their condition or refuses. I mean, I get people who tell me they're on echinacea, not St. John's wort, but something or other, shark cartilage or whatever, and it's not working. And I have to say to them, why don't you just try a bit of the natural product called paracetamol or some ibuprofen, because maybe that will help. And patients, naturally enough, particularly if it has been going on for a long, long period of time, they just want to be fixed up. And that's a very natural sort of feeling. And a lot of my discussions for patients is to at least get them on a pathway to see how they go with the other measures. Because if they do not get better doing those other measures, then that gives me a clearer idea that they may need surgery to correct their condition. There are variations, of course. It is highly individual. I sometimes do see patients that I pretty much know from the day one that I see them, they are probably going to need an operation, but I need to give them the time and be a little bit conservative in my approach before I say, look, right, it's time you need surgery. Obviously, if there's someone that comes in where the situation is dire or drastic, then you do make that decision sooner rather than later. But again, for foot and ankle conditions, I can see people with exactly the same looking foot, exactly the same level of pain, exactly the same imaging as another person, one of whom is begging for surgery and one of whom really wants to do anything other than have surgery at all. I think the second opinion, again, as I said in my previous slides, is really, really important. It helps to give a clearer picture about what you're doing. I think in a sense, it is partially defensive as well, that if there is a problem down the track, that we did obtain a second opinion prior to surgery. I usually say to my patients, decision-making for surgery, if there's another foot and ankle surgeon that thinks the same as me, that you need an operation, then without being able to give them 100% guarantee that surgery is going to work, I can at least say to them, you should be comforted by the fact that 2 people or even 3 people believe that you need an operation. And I think that's an important aspect about deciding as to whether or not people need foot and ankle surgery, probably in any region in orthopaedics as well. So specifically, just the very first slide, I won't go back to it, but I just outline the kind of things that I really like to to look at. And I would say to try and put a percentage on it. That's what I've tried to do with this slide here. In trauma, and I know I don't know how people here do a lot of medical legal stuff, but yeah, displaced fractures, dislocations, they're usually going to require surgery. Someone's got a badly busted up ankle or foot, they're probably going to need an operation. I think we can sort of accept that. Just for some general conditions, the ones that I said that I deal with more than most. For ankle sprains, really 80% of people don't need an operation. Around about 20% probably do need an operation. Of that 20%, maybe close to 30 or 40% just don't want to have an operation. So if you have something like an ankle sprain, the hardest thing to convey to people is that decision-making on your surgical management is dependent upon time. And it can be 4, 5, 6 months. I think if there is a patient who at 8 weeks is told they need surgery for their sprained ankle, they probably need to seek another opinion, because I have substantial portions of patients who don't feel that great at 8 weeks, but feel great at 16 or 20 weeks. So that's probably a common injury where it seems as though, well, if you got on and did surgery sooner rather than later, everybody would be fixed up, but it's not. It's really a case of waiting and waiting and waiting until the right time. The big one, if people follow football or any coach, is what's known as the syndesmosis injury. That's a little bit different. That actually represents in a sense, I'll use the term partial dislocation of the ankle, but certainly an unstable ankle. Around about 50% can get away without surgery, depending on how badly damaged the syndesmosis is, and around about 50% need surgery for the syndesmosis. Achilles tendon, I've said around 75% decide to have surgery in my practice. I am heavily biased in that regard. And the reason for that is, in my practice, pretty much anyone at any age with an Achilles tendon tear, I believe, will be better served by having surgery. I do outline for people the non-operative and the operative course about having their Achilles operated on. And around about 3/4 of the people I discuss that with decide to have surgery rather than not. I do say to them in a disclosure that my preference is for people to have surgery for this, because I do believe they get a better outcome. And there is a fair bit of literature that supports that. The second thing about that is actually the type of surgery that gets done by foot and ankle surgeons, which is what we call a minimally invasive system. And it is much better than what the old systems used to be. For bunions and claw toes, look, again, everyone with a bad bunion in their great toe or clawing of their toes could be treated if they got big enough shoes, but you don't want to, walk around in Ronald McDonald shoes. So again, probably around 80% don't need an operation, but just need some form of podiatry management. But once people are starting to struggle to get into shoes, and often it is that one foot is relatively straight, but the other foot is a little bit deformed. When it starts to become a problem, then I say to people, look, it's worthwhile considering surgery just in order to help get you back into shoes. For arthritis conditions, it really does depend on the site, but a lot of people with foot and ankle pathology for arthritis can manage without having to have surgery. It's a little bit anomalous in foot and ankle compared to other regions. Again, I can have people with the most horrible looking X-rays or MRI scans who actually don't have a problem at all. And on occasions, I can have people with a relatively, not normal looking, but relatively not too damaged ankle or foot on an X-ray or MRI scan who are having a dickens of a time and are really, really struggling. So that's applies more so in foot and ankle surgery than what it does in other regions. Certainly, if I see an X-ray of someone's hip where they have significant arthritis in the hip, or their knee where they've got significant arthritis, clinically they've probably got a big problem. But in the foot and ankle, certainly it does depend on where it is and what a patient is prepared to put up with as well. Now, as I stated earlier, I am not a medico-legal expert, and this is the only sort of story I'm going to tell. One of the first times I had a patient make a complaint and I got sued, I used my medical defence. The lawyer rang me up and said, "Good news, we've settled for $100,000," and I nearly fell off my chair. Subsequent to that, he said, "Well, you don't sound very happy." And I said, "Well, I don't know what I'm supposed to be happy about." And he said, "That's a good result." I then spoke with the professor of orthopaedics here, who was a bit of my mentor, and he said to me, "Pankaj, listen, you're the expert in foot and ankle. The lawyer is the expert in medico-legal. If he tells you it's a good result, it's a good result." So after that, again, whenever there's been issues I've had to deal with lawyers with respect to patients of mine, specifically in workers' compensation, I leave it to them to let me know what is a good result for the client or for me or for them or whoever's involved. When I've been involved in patient disputation, the issue has more centred on the outcomes following surgery rather than the decision to have surgery. And I don't know if that's everyone else's sort of findings as well, with the insurer or with the lawyers. I think that's often what has been called into question is what's the outcome following the surgery? Why wasn't it as good as what either the patient expected or the other people involved? In my experience, if the factors that I spoke about, doing the right sort of therapy in terms of medications, physio, podiatry, giving it enough time, most patients have been happy to have the surgery. So they're confident when they go into having the surgery that they have made the right decision. The issue then comes with you may not be happy with the result, and then that's obviously a separate issue. Again, I don't want to labour the point. With foot and ankle, whilst we do have a great big textbook for foot and ankle that we use, that's a 2-volume, 1,200-page textbook that we all read at some course at some point in our lives. The variation in the type of surgery, implants, what gets used, how people do it, post-operative courses is really variable. So again, I believe that second opinions are very, very useful. My statement on further close is just what I outlined previously, that I think you just have to not be afraid that a patient's going to leave you to go to another surgeon. I think it's just a case of actually saying, look, let's get another opinion to make sure that we are doing the right thing. I do that for my, when I get asked a second opinion, and luckily here in Newcastle, my colleagues do that as well. In other areas, it's probably well known in some areas where orthopaedic surgeons don't like each other and they'll do anything to take business off other people. I think I'm very lucky here in Newcastle to not have to be in that situation. So finally, I'd like to thank MAG for allowing me to give a talk today, because I really do enjoy doing these sort of talks, specifically for foot and ankle. I'll say it's a difficult field in which to work and make decisions, but that's my job. I am the foot and ankle surgeon who is supposed to assimilate and make a decision on what's in the patient's best interests. I think to summarise what a patient actually likes, and I'll just say this is magnified in foot and ankle surgery, patients like certainty and a plan. Whether it's going to be a 12-month plan or an 18-month plan or a 6-month plan, that's probably the biggest thing that it comes to deciding as to whether or not patients need to have surgery. I'm happy to discuss any individual questions, cases, be contacted via MAG for an opinion. Like I said, I enjoyed I've only done one, but that little summary sheet about whether someone whether there's been any negligence involved in the case. I'm more than happy to do those relatively short notice, and I usually try and get back to people within 24 to 48 hours regarding those. So thanks very much for your time, everyone. I'll just
there we go. Right? Thank you so much, Dr. Rao. That was really, really interesting. For those of you listening, when I first came on, spoke with Dr. Rao this morning, testing the link, I was talking to him about a broken bone I have in my foot, funnily enough, and how I'd chosen, it's 6 years, and I'd chosen not to do anything about it, but I've got a bony lump. And the foot is such a fascinating structure. So it was really an interesting talk for me. Do anyone have any questions that they would like to ask? You can unmute yourself and jump in. Megan, I think no? If you have a question, please unmute yourself.
Hi, I do have a question actually. So regarding amputation, Dr. Rao, I actually have a client who is coming up to a amputation with yourself. So when an orthopedic surgeon such as yourself recommends this as the best course of action, and the injured worker is keen to do so, but the other treating practitioners like the pain specialist, the GP or physio are kind of against it, what kind of happens in that circumstances? Would you encourage the worker to go with the alternate action recommended or proceed with the action you've recommended?
Can I ask, Cass, is it an amputation of below the leg, below the knee?
Yes.
Yeah. So if it's an amputation, I'll talk specifically about this case. Is that okay? I don't know who it is, but if it's an amputation below the knee, then it's like an elective kind of thing. Then it's a decision between myself, the pain specialist, the rehabilitation specialist I normally send the patient to, and also their general practitioner and physio. But specifically, an elective decision to amputate a leg has to take in all of those people. So if I've recommended that I think the patient may benefit from an amputation below the leg, but the pain specialist is against it, and a rehab specialist is against it as well, and the GP is against it, then I personally would get another opinion from another orthopaedic surgeon. As to what they would suggest, and then you'll let the patient decide. I would say if a pain specialist is firmly against it and a rehabilitation specialist is firmly against it, and I'm for it, but someone else is not for it, then I'll probably say the best situation then is I would say if no one else is happy for this to occur, then maybe it's best that we don't do it. So it depends on that case. So if that's a case where it's someone I'm saying, look, I think this is your only option, and I suspect it might be someone that I'm considering sending to another surgeon to get it done, to perhaps get some form of implant for their lower limb as well. I think I may have already done that, Cass, for that particular patient.
Yes.
So that's does it? Are we still recording, Michelle? Yeah.
Yes.
All right. I won't mention names then and stuff, but I think in that situation, Cass, if it's the one that I'm thinking about, it's more than just the below knee amputation. It's the whole process for that patient for what has gone on over the last 5 or 6 years.
Yeah, and there's lots of chronic regional pain syndrome.
Chronic regional pain syndrome, yeah.
Which was my next question, yeah.
Go ahead. Yep.
Yeah, so what kind of role does CRPS play in amputations?
Okay, good question. It plays an absolutely deleterious role. So the issue that can occur when someone has CRPS and they're going to have surgery, the big risk is that you can actually make it worse. So as bad as that person is, terribly, we can actually make them worse by doing that. However, the particular surgeon that I'm thinking of sending that patient to has done that procedure multiple times for people in that situation and has at least had better results than most. So that's the tricky thing. When there is no other alternative, that's when I would suggest to someone to have an amputation below their knee, or have their leg taken off. It's certainly not my first choice if you came to me with your bunion, right? So it's definitely based on a long history of multiple surgeries, things not working for that patient, multiple opinions from different people, including other orthopaedic surgeons and pain specialists, before we come to that decision. And at the end of the day, I'm more than happy to sit down with a patient and say, look, I think it would be a good idea for you to have it, but no one else seems to. I think it's probably best that we don't, if that's the case.
All right, thank you.
That's right.
Lovely. Does anyone else have a question that they would like to ask? No, that's good. Usually when that happens, it's because the presentation has been so good and has answered everybody's questions. In fact, I had a question for you from someone who couldn't attend, and it was about complex regional pain syndrome. So, yeah, so there we go. Look, thank you everybody for making time to join our seminar today with Dr. Rao, and thank you so much, Doctor. It has been an excellent seminar. The recording for this will be sent out to you all within a day or so, and can always be viewed on our YouTube channel. Thank you again. Have a great rest of the day.
Thanks, everyone.
Thank you so much.
All right, catch you later. Bye.